Welcome to the podcast series On Air, the podcast of the AIRR community with a special focus on the clinical use of the adaptive immune receptor repertoires. In this series, we will look at how repertoires of T and B cell receptors are currently used in diagnostics. We will also discuss different opportunities where repertoires can be a great addition and the reasons why we're just not quite there yet. The podcast series is supported by the Antibody Society, which aims to bring together everyone working with antibodies. You can find more information about the Society on the website antibodysociety.org. Hello everyone and welcome. Today with us for the third episode of On Air we have Anton Langerak, Professor and Head of Laboratory Medical Immunology at the Department of Immunology at the Erasmus Medical Center in Rotterdam in the Netherlands. Hello, Ton.
Hello, nice to be here.
We had something else planned for today, but calendars got in the way, so I also want to thank you, Ton, for joining us on this relatively short notice. The episode is hosted by me, Ulrik Stervbo.
And me, Qingding. Hello, everyone, and welcome. So, Tan, one of the aims of this podcast is to show the diversity and skills that come together in the study of adaptive immune receptor repertoires, or AIR for short. Can you start off by telling us a little bit about your background, such as how you got where you are and how you became interested in AIR?
Yes, sure. I'm actually an immunologist by training, and I was specialized as a medical immunologist, which is a lab specialist in our country. So that means I'm very much interested in understanding and applying immunology in the context of diagnostics. And for a very long time, actually since my first postdoc, I've been interested in immune repertoire analysis, or AIR as you call it, which has always been the red line in my whole career ever after.
I also see that you are an active member of EuroClonality. Can you tell us a bit about the society and its mission?
Yes, so EuroClonality actually started when I did my first postdoc here, also in Rotterdam, based on a grant that we got from the European Commission. One of the programs at that time was called the Biomet program, and so we started as a Biomet 2 consortium, and our aim was to work on optimization of PCR-based clonality detection in lymphoproliferations. And when that project was finished, we actually had worked so nicely together in the consortium that we all decided that we wanted to go on and work together. And so we renamed ourselves into the EuroClonality Consortium. And building on what we had done in the original grant project, we further worked on applying the tools that we had developed and also giving support to the diagnostic community in terms of education and diagnostic consultation service, for example.
Okay. Is that different than between the EuroClonality-NGS versus the non-NGS version?
Yeah, it's slightly different because the EuroClonality group as such was a direct follow-up of the original consortium based on this grant, which started in 2004 or something. And then after several years, we realized that what we had done was very nice, but that meanwhile the world had moved, new technologies were introduced, and so the NGS technology, that's also what came across our activities, and so we decided in 2012 or something to build a group within EuroClonality that would focus on NGS assays.
I see.
And so we also included groups from outside EuroClonality that had experience in certain specific applications, like in minimal disease testing or prognostication in CLL, for example. So we included other teams, but the basis is indeed from EuroClonality, and we are a working group within EuroClonality, so to say.
Okay. And what's the primary focus of this specific subgroup?
The focus of the EuroClonality-NGS subgroup was to develop, standardize, and validate NGS-based immunogenetic assays for all kinds of diagnostic applications, ranging from detecting clones, studying repertoires, but also minimal disease monitoring after treatment.
I see. And is this for a specific disease or open to multiple diseases?
We are concentrating on lymphoid malignancies because there, of course, the immune repertoire is a direct reflection of the actual cell. We've considered over the years to broaden our expertise also maybe to solid tumors and to the immune response to these tumors, but so far we've mainly concentrated on the lymphoid malignancies themselves and worked on that in our group.
Okay. Are those limited to just leukemias or also lymphomas?
No, it's leukemias and lymphomas and also myeloma, so it's really broad, and it's not only the acute leukemias but also the chronic leukemia, so it's the whole lymphoid part of the malignant immune system.
So that's very much into your research area. So I found that you one of your interests is chronic lymphocytic leukemias. And can you tell me a bit more what characterizes this disease?
Yeah, you're right. CLL is a disease close to my heart. I've been working there in this area for a long time, and it's a disease which is known as a kind of indolent form of leukemia as compared to or as opposed to the acute leukemias, which are much more aggressive. But I think over the years, last 10, 15 years, much more insight into the biology and the clinics of this disease has identified several subgroups, showing that it's much more heterogeneous than initially thought. If you look from it from the perspective of, let's say, the morphology or the phenotype of the cells, it seems quite homogeneous, but actually, biologically speaking, if you go into genetic aberrations and also in clinical course presentation, then it's much more heterogeneous. And I think that's where the interest comes from, to try and figure out how we can define subgroups which have different prognosis, which require different therapies, which are in need of therapy versus the ones that are more on a watch and wait regimen. So I think there's much gained over the last years, but still also much to be done in order to make those distinctions much better.
So how does BCR sequencing fit into figuring out this heterogeneity that's there?
Yeah, BCR sequencing has come in the late 90s. There's two seminal publications in the field that have introduced a concept where the CLL could be broadly divided into two groups. One being annotated as the mutated CLL group, and the other one is the unmutated CLL group, and that refers not to the genetic aberrations, but really to the mutation status of the immune globulin B-cell receptor loci. And so the unmutated group, the ones that haven't undergone such somatic hypermutations, they are known as the poor prognostic group. Whereas the more favorable group is the one that has undergone the somatic hypermutation. So the BCR sequencing has been, from that time onwards, a very central test in order to make that big distinction for prognostication. And it has also been recognized that probably also the choice of therapy could be based on this distinction, such that now in the international guidelines, this is really considered to be an important test to be done before treatment is started.
Which kind of then technical challenges are there to this distinction between the mutated and unmutated phenotypes of the CLL?
You mean clinical challenges in terms of the BCR sequencing, or in general?
In terms of BCR sequencing.
Sequencing, yeah. So I think much has been solved over the years in terms of much more standardization of protocols and also interpretation, thanks to the great work of European Research Consortium on CLL called ERIC, which has produced many standardized protocols and recommendations for interpretation. I think very important has been to also work on the bioinformatics, especially immunoinformatics, related to correct annotation of genes and making this exact estimation of the somatic hypermutation number, because that's a clear thing that needs to be done. It needs to be identified how much mutations there are. It needs to be translated into a percentage germline identity of the V gene, and a distinction is based on a 98% cutoff. So you need to be very accurate to be sure that you're classifying your case in the right group, so to say.
So you need a really good sequence, reference sequence of the V genes.
Yeah.
So how does this germline sequence definition, how well is this done across different population groups?
That's a very interesting point. I think we have so far concentrated a lot on CLL cases that have been studied in parts of the world where not all different backgrounds have been represented in a balanced way. Let's put it like that. I'm not saying that it's completely focused on, let's say, the more Western countries, but I guess if this needs to be broadened to other parts of the world, there's much to be done on correct germline polymorphism identification in the general population to have a good reference.
So, and beyond this mutational profile of the BCR, there's also different V genes that are found in unrelated patients. Can you tell me a bit about this? Because that I found quite interesting.
Yeah, that's correct. That's a concept that was introduced later on by studying in collaborative efforts many CLL cases. We started to realize that whereas against the background of the normal VDJ recombination, where you wouldn't expect two independent cells to come up with a almost identical BCR, that in groups of CLL patients we saw that this was the case. Those were referred to later on as stereotypic cases with a stereotypic receptor, which is defined as a very or almost identical receptor based on usage of the VD and J genes, but especially also the CDR3 length and composition. And the concept here is that those cases probably reflect a positive selection of certain CLL receptors, CLL BCRs, either because they are antigen stimulated, or, and that's an even newer concept, there's also an idea that certain of these stereotypic receptors actually do not recognize antigen, but rather cross-recognize each other. So there's auto-aggregation of BCRs on the CLL cells, which provides the activation signal to the cell itself without any antigen coming into the picture to activate the cell. So it's really the cross recognition of the BCRs on the cell surface of that individual cell that delivers a signal to the activation signal to the cell. So stereotypy is biologically quite interesting, but it's also clinically meaningful because we've seen over the years that, for example, in the more favorable prognostic groups, so the mutated CLLs with the somatic hypermutations, that you can identify subgroups of stereotypic CLL cases with a stereotypic BCR, which do clearly more poorly than the general mutated group. So I think based on this broad distinction into the two groups, there's more that is also not only biologically interesting but also clinically meaningful that we are probably gonna expand on in the coming years even further.
And how in practice has all this sequencing of the B cell receptor impacted the CLL community? So from both patient and physician perspectives.
Yeah, I think very much because this concept of the prognostic subgroups has been quite well accepted. The stereotypic subgroups within the two main categories is still something that is more in a research context, although clinicians also are getting more convinced about the added value of certain of these stereotypic groups. And so the whole idea of knowing all these sequences for prognostication, I think, has landed. And on top of that, of course, it also allows you to follow the patient with a very specific fingerprint for the leukemia if patients are being treated. So the minimal disease monitoring has also been introduced now in CLL. It has been known longer time in other leukemias like in ALL. Myeloma, it's also quite established, but also in CLL it's getting more and more attention and translates now from being used as a surrogate for success of a therapy into potentially a marker that one could use to guide next decisions in therapeutic approaches. Being if it's an undetectable level of MRD, treatment might stop, or if it's still too high, then treatment might be continued or changed to get deeper remission, for example. So yes, the impact has been very big, I think, in CLL. And much of that has been based on the Sanger sequencing initially, because when it started, late 90s, it was Sanger sequencing based. And gradually what we now see that is transforms also into the next-gen sequencing protocols where, of course, much more information can be gained, but it also comes with, certain pitfalls and biological challenges that we have to tackle now, because we all of a sudden see additional dominant clonotypes popping up, and well, we have to figure out what the meaning of that is. Is that additional CLL clones, or is this the normal immune response in the background that we're looking at? I think so. NGS technologies come with, of course, much more easy way of working, much more high throughput way of working, but also with certain interpretation problems, I would say, that we have to tackle now and find out how we should be dealing with it.
Yeah, so you actually have a really interesting paper coming out in the journal Blood, which is looking at or utilizing the sequencing of B cells within CLL patients, but you're looking at it some 20 years prior to their prognosis. Was this paper based off of the Sanger or the NGS?
That paper was based on NGS.
Okay.
So what we did here, we were very lucky to get access to a population cohort in Europe where like 100,000 people are followed over time, and they have been sampled at some point when they were in a kind of, let's say, healthy state. So without knowing what their follow-up would be. And so the registry has very accurately documented what disease those persons would develop in the end. And so we selected cases that finally developed CLL and went back to the original sampling way before their CLL was diagnosed. And so in most individuals we had a single sample, pre-diagnostic sample, and that could be close to the diagnosis or it could be much longer away. And by having a nice series of cases and a matched set of controls that we matched for age, for the length of their follow-up, for gender, we could identify in the cases that finally developed the CLL clonotypic shifts in the IG repertoire, in the pre-diagnostic sample, that showed a clear dominance of the clonotype. And in those cases where we were able to compare that to the actual diagnostic material, we could also see that this was the identical clonotype that we already saw way before. And way before means that we even saw now shifts in the repertoire that were prior to the occurrence of a clear lymphocytosis. Because in CLL, it's well known that lymphocytosis can be present years before the actual disease is clinically present, and that's called monoclonal B-cell lymphocytosis. It means a monoclonal set of B cells which is simply in numbers higher than one would expect. But in the study that we did, we could also identify cases based on the clonotypic BCR that were even before that clear lymphocytosis. So really pushing back the in time the period of a pre-diagnostic detection of the CLL.
Do you think BCR sequencing or AIR will provide better early detection for these NBL patients to help? Because I believe right now they're basically in this wait and see kind of pattern.
So I think yes, we can surely, if we use those methods, detect such clones earlier. Question is, what do you do with it? And so what is the clinical impact of that? So our study was not so much meant to really be translated directly into clinical practice to screen everybody in order to find persons who might have a clone because there's no action on such clones. CLL patients are starting to be treated only when they have clinical complaints and when there's a need for treatment. So if you would take the moment of detecting such shifts in the repertoire as the starting point for treatment, then you would have to have a treatment which really would give benefit to the individual, and that's not the case at the moment. So I think this whole study at the moment is more of a biological study showing how long before actual overt CLL these clones can already be there. But what we're trying to do is to translate this detection into situations where we're not going to screen a whole population, but rather would like to have a possibility to screen patients at risk. So it's known that certain lymphomas develop in the context of certain conditions, especially conditions where the immune system is blocked or is deficient, like in primary immune deficiencies or in people that get transplants, for example, that are under immune suppression. So it would be interesting to translate what we've seen now in the CLL study to such patients to see whether the concept also holds true, that you can detect way before the disease really shows up clinically, because that would potentially be a much earlier detection in a group which is relevant to check and to screen. And then again, of course, you need to understand if there's possibilities to start treating those patients earlier. But given the sometimes quite aggressive diseases, lymphomas that those patients develop, I think it's, if I talk to the clinicians that are involved, it's really something they think is interesting to do, to start working on new therapies way earlier than when the disease really is there.
I see. Yeah, I wasn't aware that there was an association of immunosuppressants and having an increased risk of developing these lymphoproliferative diseases. So you're saying that are these patients also more of the mutated and unmutated subtypes, or are they a completely different classification to the healthy or sort of more normal population?
Well, the immune suppression phenomenon, I think that relates more to the transplant patients. So that's a little bit apart from the CLL story. I'm not sure whether we simply haven't data for that. We haven't studied it. I'm not sure whether immune suppression could play a role in CLL development as well. But I'm trying to translate the concept that we've seen in the CLL study into actionable, relevant patients group at risk, and one of them could be the post-transplant follow-up of those patients, given that they have a quite high chance of developing lymphoma under their immune suppression.
So how would you practically do this? So would you track the patients over time and see how are the dynamics of the repertoire changing, or how could one do this?
Yeah, I think that's a good question, because just having one measurement in time, will that be enough to understand that there is something coming up which might last still for several years, for example? No, you're right. I think the way we want to approach that is to show that that there is consistent detection of that PCR clonotype, first of all, and also ideally that indeed you see some kind of dynamics showing that it's increasing, so that makes you more comfortable with the idea that this is indeed a process that doesn't go away, and what's more, that even probably becomes more prominent. And of course, it needs to be proven, the whole concept, in prospective cohorts, to know how much or how many cases we have where these dynamics would not lead to a lymphoma in the end, or whether it would be exclusively happening in the cases where lymphomas do occur. But dynamics plays certainly an important role there.
There generally seems to be a focus of AIR in malignancies of the blood, so either in diagnosis, also, as you mentioned a couple of times, tracking of minimal residual disease. Why do you think this is? So why this focus? Is it because it's really just a low-hanging fruit and the samples are easy there, and somehow a logical step to look at the receptors in these things, or other things that plays a role in this?
Yeah, I think it's probably a combination of things you mentioned. It is to a certain extent certainly low-hanging fruit, because the samples are more easily available, because you can simply take some blood and analyze what's there. So I think that's a clear advantage. The other thing, of course, is that by definition, lymphoid malignancies have these markers, whereas if you would extend such AIR analysis to solid tumors, you would not so much look into the tumors itself, but rather in the immune environment, which also could be very informative. And I think there's more and more evidence also there that in the context of newer therapies, where checkpoint inhibition is being used, or CAR T therapies, that it's very important to understand how good the T-cell immunity is. And one of the readouts for that could be to study for example, TCR repertoire, to have an idea of how successful certain therapeutic choices might be. So I think it's probably indeed the low-hanging fruit that made it easier to study those malignancies first. But I think you can expand on those concepts and start looking at other malignancies as well. And we also started with leukemias more than lymphomas, and that also has to do with the circulation of those leukemic cells in the blood, and lymphomas often being more restricted to nodal areas in the lymph nodes, or other extranodal areas in tissues. So also there, the excess of the samples has hampered the progress a bit. But nowadays, I think with the cell-free DNA options one has, it could be interesting to also look in the plasma DNA and study even nodal processes based on blood plasma in terms of these BCR, TCR sequences.
So you've been working with AIR sequencing in clinical settings for quite some times. What aha moments have you had in these years, in this time that you've been working?
Hard moments.
Not hard. Aha moments.
Oh, a hot moment. Oh, okay.
Eureka moments.
Yeah, I understand. That's quite different from hard moment indeed. I also had hard moments, by the way, but hot moments, eureka moments. I think there was already in the very early days with this Biomed consortium, because we really, I think at that point, did something different by having a much more complete set of primers that was much more not so much sensitive, but the coverage of those primers together in the combinations. We not only targeted the heavy chain, but also the light chain, not only gamma chain of TCR, but also beta chain. That really made a big difference to what was available, and so has really, I think, supported the diagnostic community in an enormous way. And actually, those assays that we at that time developed have also become the world standard for diagnostics in the low throughput times. So with fragment analysis or gene scan analysis as readout. And I think that was one of the most interesting and rewarding moments in that period. And in the same way, I think we've been working along that same line, trying to improve, working on next generation sequencing assays. And also there we've been successful in delivering assays, I think that are also very useful nowadays to a broader community. So history has repeated itself in that sense, I think, and also after this new standardization effort that we did in the NGS working group, I think we've come really to the same point.
So, which obstacles then do you see in bringing the AIR sequencing even further into the clinic in general, not just for blood malignancies, but in general?
Well, I think technically there's a lot already possible because many protocols have been quite well standardized and there's good procedures there. I think the obstacles would probably be more in data interpretation, in correct informatic pipelines, in calling clonotypes very accurately. Those kind of things. I think the AIR community has several efforts that are in this direction as well, and in our working group we are also concentrating on that more and more. So technically a lot is possible, but if you start using it, you need to make sure that also data interpretation is robust and accurate, and I think there's the big challenges now in further bringing this to clinical practice.
Do you see any standards I'm missing to bring this? So you've done a lot of work for to standardize the biological assays, but do you then see some sort of standardization missing in terms of the data analysis, and how would one go about doing this?
Yeah, I think the main aspect that is probably still to be completed is the data interpretation, especially guidelines for doing that, so that in translating that into clinical decision making, that we know that if this is performed anywhere in the world, it would result in the same result, first of all. I think that is quite well covered by having standardized assays, but also that researchers or scientists that interpret these data, that they follow certain principles, recommendations, guidelines, whatever you want to call it, that make this reproducible so that it's done in the same way for every patient. I think there's the main challenge at the moment.
You mentioned that AIRR sequencing is starting to become an accepted endpoint for CLL and multiple myeloma. Is the European regulatory agencies, are they participating or at least trying to harmonize the types of assays and the analysis, the bioinformatical analysis that you spoke of?
Yes, to some extent, and some of these trials in which this is evaluated are, of course, international trials, so also FDA plays a role here. But I think there's indeed pharmaceutical trials that have used also in CLL MRD as a surrogate endpoint for outcome, and in that way helped to understand the relative benefit of new therapies or combination therapies over old ones. So that concept is quite well accepted in certain registration trials that have already taken place. I think the main challenge now in the CLL field is to transform MRD from a surrogate endpoint into a actionable measurement, so that, of course, first to be evaluated in trials as well, but finally in clinical practice for individual patients in the real world, we know how to act on certain residual levels of the cells in terms of stopping treatment or continuing treatment or intensifying treatment.
Well, thank you. This brings us to the end of the third episode of On Air, the podcast of the AIRR community with a special focus on clinical use of adaptive immune receptor repertoires. This podcast is supported by the Antibody Society. Any questions or comments, drop us a line at onair@airrcommunity.org. That's ONAIRR@AIRR-community.org. Or tweet us using the hashtag OnAir. That's with 2 R's.
Thank you for talking with us, Ton. It was a real pleasure having you.
It was my pleasure as well. Thank you.
The podcast will return in 1 month's time with more thoughts on the clinical use of AIRR sequencing. And we have an announcement, actually, for the first time in this podcast series, because the AIRR community will meet, and it's the 6th meeting of the AIRR community that will take place in May in La Jolla, and the organizers have put together a very exciting program. So head over to the website of the Antibody Society, so that's antibodysociety.org, or just click on the link which will be present in the show notes for this episode to get more information about the program and registration for the meeting. The podcast is edited by Abdul Aziz of the hilarious podcast Spout Law. Thank you for listening to On Air.